First of all, I'd like to thank Dr. Devashish to have given this chance to me, and he calls it double trouble. So you have iridodialysis and a zonular dialysis. So I'll show two videos. I know the paucity of time. This was a traumatic subluxation and a bit of the iris that was lost, and there was vitreous coming out. So I go ahead, put Kenacort, and do the staining. I do a little bit of angiovitrectomy. This is a trick that I like to use before we put the endocapsular ring. So I like to put the viscoelastic below the anterior capsule till the equator of the lens, and that pushes the cortex down. Once that is done, I'm going ahead and doing this all around. Then I thought I will put capsular hooks, but I have now decided to put the endocapsular ring to give me additional support in the subluxated area, which you can see through the iridotomy which had happened during the injury. So this is a endocapsular ring going there in that area. Once that is done, I thought I'll need additional support with capsular hooks, but it was quite tricky. So to make a side port for capsular hooks is very different than that you make for iris hooks. So this is one support that I got. Once that was done, I went ahead and did phacoemulsification. And once the phacoemulsification, you can see that this lens is not all that hard. So I'm going to remove this cataract, and once that is done, we put a lens. And then I will show that how exactly the iridotomy which had happened, we will suture it or not. So this is the phacoemulsification that is happening. And once the phacoemulsification is completed, because the way we injected the viscoelastic below the anterior capsule, you will see that there is no entrampment of the cortex at all. So this is a bimanual IA. Since the endocapsular ring is supporting the area of the subluxation, the capsular hook is just hooking on to the margin of the capsule, but that's okay. It really doesn't matter because the stretch on the capsular bag is quite good. So there is no fear as that part is concerned. So once I've done this, now we'll go ahead and put the IOL. And once you put the IOL, you'll see that how are we going to repair. Now I realized that the capsular hook had no play at all. And so we removed it. We go ahead and put the lens in the bag. Now, all the steps, you will need little micro forceps or fine forceps like a micro grasper so that you can hold the iris to do a fourth row pupilloplasty. So I didn't repair this. You will see at the end of the procedure that when we pull the iris with the micro grasper, there is a huge iridotomy which had happened at the time of the injury itself. So once the lens is in the bag, we go ahead and use the micro grasper. And once you can see that little bit of pilocarpine, and now you can see the huge iridotomy. So part of the tissue of the iris is actually missing. So this is a micro grasper that I'm using, and now I use a technique invented by Amar called the fourth row pupilloplasty. So I decided that, instead of going through a 26 gauge needle, sometimes I find that it itself causes a bigger bore. I like to pass a 9-O-proline through the iris itself and then hold the iris on the opposite side and pass again the needle through that instead of putting a 26 gauge to the opposite side and then doing a railroad. So this is what I have found, that if we use a 26 gauge, the 9-O-proline is much smaller. So I like to hold the iris itself and then push the 9-O-proline across the iris instead of putting it that through a 26 gauge. So this is one sweep that you can see. And once that is done, again, get the loop inside and then a 4 loops, that's a 4th row. And then just pull the 2 threads and it will bring the iris into good opposition. So you can see that once that is done, we go ahead and just pull the threads on either side. Once that is done, you can see that the pupil is becoming nice, small and round. And then you need micro scissors to be able to access that area. And the same thing will be done twice, say second, 4th row pupilloplasty, and you got a nice round pupil. So this can happen. There was an area of subluxation which could be quite easily managed, and the lens was in the bag. I'll show you one more case. This is a very interesting history. The patient comes to me and says when he sits, he cannot see, but when he's lying down on the bed at night, he can see very well. So the question was why that really happened. So this is how the patient came to me. You can see an endocapsular ring with the lens and the whole back complex which is subluxated. So this history was very interesting. So when I said, how can you see? Because when you will see when he lies down on the operation table, you will see that the whole bag is very well centered. And that's the reason why he could see very well. But on the slit lamp examination, this is a video on slit lamp examination, you can see that the whole back complex has gone down. Now the question is what to do about this back complex which has gone down, and now the patient is lying down. So yes, I did put a port to support me from a little bit of irrigation to give us support on the either side. So there are many ways of handling this. One is to remove this whole back complex and do a glued IOL, remove the whole back complex and do a iris crop posterior fixation. But I thought of something entirely different. So I decided to suture this same back complex back in its own position. So here you can see that I'm putting viscoelastic. I did a Hoffman's pocket, then do a railroad technique. From here, I'm passing a 26 gauge needle from below. The spot here that is very, very important is here I got the endocapsular ring and the haptic of a Technis 1 IOL. The same spot, remember friends, we have to take it on the opposite side. You can't do it, otherwise you'll have a cyclo-rotation. Of course, it's not a toric IOL, but remember I marked it. So you'll be able to see that. And this is a railroad technique. So one suture goes from below, and now I'll pass the same thing again. Again, the needle is going through, and another 26 gauge needle goes from above the endocapsular ring and the haptic. So this is above, just behind the iris, but above the endocapsular ring and the haptic. So this is like creating a loop, which is around the endocapsular ring and the haptic. So I've got this back into position, and the same thing we will do on the opposite side. So remember, friends, as I said, 90 degrees across, the same spot of the optic haptic junction or where the endocapsular ring is what you have to capture. So here again, this is from below. I've got the endocapsular ring above and the haptic of the IOL above the needle thread that we have just passed as a railroad technique. And the other one will be above. So the one was below and this is above. So it's again creating a loop around the endocapsular ring and the haptic. Once I got this on both the sides, I will then tighten this. So I've actually sutured the endocapsular ring and the haptic back into its position without removing the whole thing. So this is quite possible now. So I've sutured on one side. So we really didn't need to do any explantation or anything here. And this we got and we very well centered IOL, sutured the conjunctiva, and this is how I've captured the same bag into position. Thank you for the paucity of time. Thank you very much again, Debashish. You have given this chance to me. I finished well before time.